has a pointing option here. Okay, good. Yeah, point us there. So these are my disclosures. We have an ongoing Gilead-funded study looking at the impact of hepatitis C treatment on the quality of life. This study has finished enrollment, but we're going to continue following 150 people, looking at things like whether hepatitis C cure has a positive effect on people's ability to get jobs and feel good. And we have it seems to be forever pending, but hopefully we will finally get the business agreement signed on a project for eliminating hepatitis C. So I was very impressed by Mina's talk about acute liver failure and the way she tied it to a case report. So I decided to take inspiration from her presentation and start with a case report of my own. In this case, a 47-year-old male MD PhD with a past funding history that includes a KO8 on gene expression changes in response to hepatitis C virus replication in cell culture, and an R01 on IL-28B polymorphisms and their importance for hepatitis C treatment response in patients treated with interferon-based therapies, which is up for renewal. Now, his 2017 submission to AASLD was rejected, and he's very stressed out. He'd be stressed out under any circumstances, but of course with NIH with its 16% funding and his rejection from the liver meeting, he's very nervous. And he's referred to me for advice about options for future funding and high-impact investigations in hepatitis C. So my first suggestion is that we need to determine the hepatitis C prevalence and mortality rate by age, sex, and race in the United States. I think this is a really top priority for hepatitis C research. Second, another option would be to define the drivers of post-SVR liver disease progression and HCC development in the DAA era. And the third would be to identify factors that stimulate the regeneration of healthy livers. And the reason I put this on the list is because under the best of circumstances, by the time we are able to identify hepatitis C patients and get them into treatment, at least a significant minority, if not the majority, are already going to have advanced liver disease or liver cirrhosis, and restoring them to good health is really going to be dependent on doing a much better job of understanding how to stimulate liver regeneration without at the same time stimulating liver carcinogenesis. So this data is one of the reasons for my #1 point about the need for research into basic hepatitis C epidemiology. So this is data that came out from the CDC, came out in 2014 in the Annals. And what it showed was that between 2000 and 10 years later, there was actually a loss of 500,000 hepatitis C positive patients in the United States. And at the time that the CDC published this, they actually opined that the reason for this decrease was because the people had died. So this is 500,000 people with hepatitis C dying. But I was even more alarmed when new data from NHANES. So NHANES is a national survey of health and nutritional data, which I'll explain in detail in a little bit. But when the most recent data came out, it was just published in Gastro in 2017, the new estimate had gone from 2.7 million to 1.7 million, which you'll notice that's 1 million people. So first we lost 500,000 and now we lost 1 million. So that's pretty scary. So to understand that information, you really need to understand how information about the prevalence of hepatitis C is collected in this country. Really, our only solid national data comes from NHANES, and the data that I just mentioned came from a survey of only a little over 8,000 people. So for a national survey, this is a pretty small sample size. And they only actually found 67 people who had hep C RNA. And from that information, they extrapolated to a national total of 1.7 million people. So you can see this is pretty thin information for making national prevalence estimates. Nonetheless, they did note some important findings in addition to the loss of 1 million people. And that was the prevalence was highest among blacks, veterans, people in poverty, and people without insurance. And the reason I particularly highlight the lack of insurance in a talk about epidemiology is because it's very common when people are studying diseases to go to insurance claims data. And from that information, they estimate prevalence. But if you have a disease which is concentrated in a population that does not have insurance, that's going to result in tremendous underreporting of the prevalence of the disease.
Andrea, I would add NHANES is non-institutionalized.
I'm getting to that, but thank you, because that is a very important point. But first, a little bit about what NHANES is. So it has been in existence since the 1960s, and despite its limitations, which Jean just pointed out, it's really all we have to go on. These guys are really the only people out there systematically collecting data about health and nutrition in the United States. And they do it in an ongoing basis. So every year they do interviews and physical exams on about 5,000 people. They collect information about social habits. And as Jean pointed out, this is a survey of people living in households. So if you are homeless or you're in prison, you are not part of the NHANES study.
Or in a mental health institution as well?
No, you have to be, it's households.
I
So,
understand, so
no,
it's excluded as well.
correct. I don't think they would be,
Institutionalized.
I don't think they would be considered a household. It's used to estimate disease prevalence, and it gives us our national standards for height and weight. So the strengths, at least it uses a consistent way of analyzing things. So yes, people in prisons are not included, but it's not like they used to be included one year and they're not included this year. They have consistent methodology, and they sample the whole United States, but they don't sample everybody.
This is from this NHANES is part of the CDC?
Correct. And this is how they do their physical exams. They have these vans that they, mobile exam rooms, and these are some of the diseases and conditions that they focus on, including infectious disease, diabetes, obesity, and sexually transmitted diseases. So getting back to the loss of 1 million people, I decided to do this sort of back of an envelope calculation. Starting with 3.2 million, now the most recent data, a decrease of 1.5 million over 14 years gives you an annual number of losses, maybe due to death, of 170,000 people every year with hepatitis C. So I just wanted to put that number in perspective. So this is from the National Center for Health Statistics. So for 2015. deaths. So this is heart disease and cancer, our big ones. And then we have this intermediate group that are in the 100,000. Notice diabetes and influenza down here. So in 107,000, this is where Hep C would go in our lists of deaths. So, is it possible that 107,000 people are dying every year and nobody is noticing, or is this an artifact? So, I went to the CDC, and this is what Scott had to say. See, so you always go to Scott's for information. We too have analyzed the NHANES data, and we agree with the calculation of 1.7 million with wide confidence intervals. He's pointing out that there were only 67 positives and a sample size of 8,000. He also points out, as Jean did, remember, it's a household survey and misses the incarcerated and the homeless. In other words, an underestimate. He's saying, as best we can tell, we've got about 35,000 new cases of hepatitis C every year. And as far as deaths are concerned, on the basis of death certificates, Hep C deaths exceed all other infectious diseases combined. That's assuming, that's just taking at face value what's on the death certificates. But they did a study of a well-characterized cohort, and what they found was that of the people that they knew who had hepatitis C who died, only 19 had hepatitis C recorded in the death certificate. And they think that's the biggest survey that has been done of people with hepatitis C dying. Nationally, over 20,000 death certificates mention hepatitis C. So here's the big shocker. He actually agrees with my back of the envelope calculation. Over 100,000 Hep C infected people are dying per year, and this would be in people diagnosed with hepatitis C. And the CDC still thinks about half of all Hep C infections have not been diagnosed.
So how many are dying of Hep C related conditions?
Good question. We'll get to that in just a second. So this just gives a little bit more fine-grained detail about the previous slide. So they evaluated about 12,000 people in this cohort of chronic hepatitis C. This gives the characteristics of the people who died. 19% had hepatitis C listed as the cause of death. But interestingly, for the people who died of liver cancer, only a third had HCV recorded in the death certificate. Most of the people with hepatitis C who were dying had a FIB-4 score that indicated liver disease, 76%, and they even had in their medical record an ICD-9 code specific for liver disease in 2/3 of the cases. So even in this well-characterized HCV patients, it was listed in only 19%, but chronic liver disease was recorded in 2/3. So they conclude that the majority died not only with, but possibly from hepatitis C. So this shows a bit of the underreporting. So here you have, it's really kind of surprising. For patients who were listed as having liver-related condition as their cause of death without alcohol, still 2/3 did not mention hepatitis C. For patients who died of liver cancer, only a third had hepatitis C mentioned. If you look at patients who were co-infected, virtually never was hepatitis C mentioned, only HIV. And I just want to put this in perspective. Why do we know so little about hepatitis C, epidemiology, and hepatitis C in general? A great deal of it has to do with the way research is funded in the United States. So just to illustrate this, I went to the NIH website. that lists PAs and RFAs. And I started reading down the list, keeping track of the announcements for HIV research and announcements for hepatitis C research. So once I got to 20 for HIV and none for hepatitis C, I stopped counting. So I'll just say it's a 20-fold excess of HIV to hepatitis C. But if you look at the deaths, it's 20 times hepatitis C to HIV, even if you use these numbers, which we think are off by a factor of 5. But if you use these numbers, the ratio of deaths of hepatitis C to deaths from HIV is actually 120 to 1.
While we're on the topic, is the opioid epidemic leading to a parallel uptick in HIV?
Some increase in HIV. That's actually how they picked it up in Indiana, was they found that people were coming down with HIV. So the data on the Hep C epidemic are very fragmented. I've mentioned we get data from NHANES. We get clinical laboratory submitted to state health departments. There's this thing called the National Notifiable Diseases Surveillance System. And finally, the CDC has its Sentinel Counties studies, which focus on acute hepatitis C infection. So this is from the CDC website. So they're explaining here, conducting surveillance for acute hepatitis C on a national scale is difficult because there's no serologic marker for acute infection. So honestly, if you were looking for a research area, I do think having a serological test that distinguishes acute hepatitis C from chronic hepatitis C would be enormously helpful. We don't have that yet. And because we don't have that test, it's very difficult on a national level to distinguish acute infection from chronic infection. And when it's been investigated, it has been found that the reporting of acute hepatitis C to the National Notifiable Disease Surveillance System has been unreliable. That's the CDC conclusion, not mine. And therefore, what the CDC looks to are their Sentinel Counties studies, where they investigate patients on a case-by-case basis to determine whether they have acute or chronic infection. But because that's a slow and arduous process, they can only look at a very limited section of the country. So as far as the state reporting requirements go, and again, I took this directly from the CDC website because I thought the language was so interesting. The following information provides a comparative glance at the variation of state reporting requirements for viral hepatitis. Use of any provision herein should be contemplated only in conjunction with advice from legal counsel. So this is what it shows. I just picked out a few states. So Scott was just mentioning the opioid epidemic, fairly rampant in New Hampshire, for example. And if you look at their hepatitis C, live free or die, no Hep C reporting requirements. Now, some states, New York is pretty much a model state as far as hepatitis C recording is concerned. So Hep C is reportable. You are supposed to report acute infection, but you in New York also are supposed to report chronic infection from a standard test. Unfortunately, very few states require reporting from the rapid point-of-care tests. So anybody who's doing community-based surveillance, those results might not make it. Very few states look to ALT. Many states only require reporting if the test for hepatitis C RNA is positive. But a few states, like New York, require both positive and negative tests. And that information is important because it allows you to see how your screening is doing, which you really can't do if you only get your positive test results. And I just thought it was an interesting thing that they said from Oklahoma. Due to limited resources, Oklahoma is limited to tracking acute HCV in persons 40 years or younger, or in persons who have hallmark hepatitis symptoms. In other words, no chronic infection is followed at all in Oklahoma. And I think, again, this attitude just underscores the complacency that the country has shown to hepatitis C. I wanted to show you some, or return to some data that Doug actually presented in his talk, which has to do with hepatitis C in women of childbearing age, specifically in Kentucky. And this is their study, which was published in MMWR. And it shows this frightening increase in hepatitis C in Kentucky children, and that is in contrast to the steady pace in U.S. children. So this might lead you to believe that there's some rampant transmission of hepatitis C going on in Kentucky, but at least the problem is restricted to Kentucky. But then, if you look and you see what the Kentucky hepatitis C reporting requirements are, you find in Kentucky, perinatal hepatitis C, infants born to mothers with HCV, and children under the age of 5 are all required to report. So I think this flat curve nationally could simply reflect the fact that Kentucky has different reporting requirements than the rest of the country. So what goes to this underappreciation of the seriousness of hepatitis C infection? Well, it's an asymptomatic infection for a long time. There's really no advocacy group. And again, this is the words of the CDC, not mine. Maybe because many patients have experience with injection drug use. They speak to compassion fatigue from HIV, AIDS, and other large-scale public health problems. A therapeutic nihilism about the cost of treatment, but they conclude the unabated increasing trend in HCV-related deaths underscores the urgency in finding, evaluating, and treating patients in the largest infectious disease epidemic in the United States.
Oh. Is that Doug?
It is. It is. And he didn't even come to see it. But this statement is really true. This is taken from a study that was published in Journal of Viral Hepatitis in 2017. And it summarizes the effort that Honey spearheaded to improve the testing of baby boomers here at Mount Sinai. And you can see the trend line over time with improvements following the addition of an electronic alert, education of the house staff, feedback, and patient navigation. You can see that the house staff was quite amenable to improving. Unfortunately, the faculty really lagged behind. So we continue our efforts to improve hepatitis C screening here at Mount Sinai.
In fact, all faculty, not liver faculty.
You know, it's all faculty, right? So on the treatment side, Honey was the site PI of a 3-year CMS study called Project Inspire that provided care coordination, and she worked on this along with Jeff Weiss and Brooke Wyatt, who was the program manager, and the mission was to support care coordination and improve hepatitis C cure rates. And I'm sure many of you had positive interactions with Project Inspire. We're going to be re-upping the program with a Mount Sinai HCV Cure Initiative. In the previous time period, about 750 people were enrolled and 440 people were cured with a cure rate of 60%. With much lower fall off between identification of cases and successful treatment than in many other programs. Additionally, there are, in 2017, plans for expanding screening into the emergency department, where we anticipate finding about 40 new HCV-positive baby boomers per month, and also screening in the OB clinics with Rhoda Sperling, and Tatiana is going to be spearheading the initiative from the liver side. So, getting back to our 47-year-old male PhD. So, I've done my best to inspire some enthusiasm for Hep C epidemiology, but this guy goes, you know, I didn't spend my time learning to pipette to turn myself into an epidemiologist. So what about these drivers for post-SVR liver disease progression in HCC? What's the thing there? Well, you could look at HCC risk, fibrosis, inflammation. So we arrive at the question, among patients cured of HCV, with DAA-based treatment, what happens to the HCC risk? So we're going to have a show of hands. How many say, so does DAA treatment change the HCC risk? Any takers for no impact? 1, 2. Pardon?
Depends on the presence of cirrhosis.
Assume they're cirrhotic. No change, no change. How about reduced risk? Oh, the majority say it reduces risk. Great. And how many say it increases risk? Okay, good. Glad I took the vote. So this is a wonderful publication by Augusto, and he summarized in 2016 that cure has little, if any, impact on HCC risk if you start with somebody with cirrhosis. So I think we had 2 votes for this. Obviously, Augusto, he wrote a great paper, but it didn't seem to move a lot of minds.
There's more data.
Yeah, exactly. That's what we're getting to. So in 2017, the Hanover group came up with this data. So they took an untreated control group and they looked at HCC in the patients who were treated with interferon-free regimens. I just want to point out, these are days here. So this is 400. So here's your 1-year mark. Here's your 2-year mark. And I should have increased the p-value so you could enlarged it. It's 0.4. They found no statistically significant decrease in the HCC risk. So they concluded that interferon-free therapy does not change the midterm risk for de novo HCC in patients with liver cirrhosis. But on the other hand, as Augusto's saying, there's yet more data, and here's some of it from Gastro. So these authors, El Sharrock's group, concluded among patients treated with DAAs, SVR was associated with a considerable reduction in the risk of HCC. So, what could account for these findings? So let's go back. What could account for the difference between the two studies, the Hanover study and the VA study here? Jim?
I saw your slide already. So
Good, and a very honest man.
these are patients who were treated but didn't achieve an SVR, right? And
These did not achieve an SVR.
with the AA. So perhaps there's something about their biology that they weren't able to achieve a cure, so they were inherently at higher risk of mortality versus in the other study. I think it was.
Beautifully done.
With a little.
Yeah, people just want to believe there's no need for randomized controlled trials, but it's really hard to reach firm conclusions about the benefits or risks of an intervention if you don't have a comparison group. And if you simply round up people and you treat them and then you look at what happens, you truly have no idea what might have happened if you had not treated them. In this case, it's particularly fraught because we know that the people who are at risk for HCC are also at higher risk for being treatment failures. And there could be technical limitations to identifying early HCC before people are treated. And I just want to return to the time frame here. So these are months after treatment. So remember, the other study went out over 2 years. This is 2 years over here, this blank area. So most of the HCCs that they're picking up within 12 months after the end of treatment. And I think pretty much everybody would agree, based on what we know about the doubling time of HCC, that most of these tumors probably already existed before the person ever was treated. And Penny and I have got some data that is somewhat supportive of that, looking at the Mount Sinai population. The patients that we find who developed liver cancer or were diagnosed with liver cancer in the first few months after the end of treatment, if you go back and you look in their medical record, you often find that their doctor was already very concerned about something that they saw in an imaging study. So, hot topics. We need some technical innovations, and there's a lot of attention being given to innovations in the identification of biomarkers and other non-invasive indicators of cancer, and also biomarkers of patients at high risk for developing HCC. And to just show how hot the information is, this remarkable study was published in Gastro, even though it's a study of only 10 people who have new HCC and 10 controls and no validation cohort. I find this remarkable. But in any case, they did find these factors to be present in patients before they were treated as identifying patients at high risk for developing HCC after they were treated. So I decided to do some imagining of my own. Just in general, when you think about what types of methodologies have been effective at diagnosing cancer, you know, we have colonoscopies, we have mammograms. Imaging just has been a pretty successful way to identify early cancer. And it seems that imaging could be very effective, or more effective than it currently is, in detecting HCC if there were some technical innovations on the imaging side. So one of the things that limits our imaging capabilities, particularly by CT, is the radiation dose. But just imagine what it would be like if we had X-ray detectors that could improve the sensitivity, say, by a factor of 10. Then more imaging might become a possibility. So I have been interested in the idea that imaging could be much more useful in liver disease detection and classification for many years. And as a kind of an offshoot of this interest, Punny and I have joined up with the Mount Sinai radiologists who are doing lung cancer screening. And our first initiative is looking at liver steatosis. So I just thought I would tell you a bit about this, even though it's a departure from HCV, because I think this kind of thing is going to become more widespread, and I actually do believe that we will have innovations in imaging that will bring down X-ray doses.
Well, what I know Bashir here is testing the efficacy of fast MRI.
Yeah.
Obviates the concern,
Yep.
right?
Yeah, if you were that writ large. I noticed that when Laura Beretta was here, even though she's someone who has spent decades trying to identify serum biomarkers, what she actually said was that she thought that they would use the serum biomarkers to identify the high-risk patients who they would then study with imaging. So I think if we could wrap up our imaging enough, perhaps this could be complementary to some of the other modalities. So, NASH, CT scan of the liver. So, in a normal liver, the hepatocytes pick up the signal, and you have what's called high attenuation. And with NASH or fatty liver, you have low attenuation. So you can take this score and use it to back calculate fat. And various studies have done this, and in some cases, it was done on, for example, living liver donors. So they got the CT and the liver biopsy on the same day. And it actually works quite well to identify moderate to severe steatosis. So 40 Hounsfeld is a practical cut point for 30% liver fat, which is the definition of moderate to severe steatosis. So Punny and David Del Bello and I worked with Claudia Henschke and her group in an investigation that compared the attenuation of various patients and also looked at regions of the spleen as a comparator. And we found two groups: no excess fat, and then we identified risk factors for having fatty liver disease. And I'm quite interested in this finding of an association between fatty liver disease and eczema, emphysema, and we're hoping to drill down a bit on the mechanism that might connect hypoxia.
It doesn't change the amount of liver that shows up on the scan?
No, you get plenty of liver. So we are now working with computer scientists to automate the process so that we can actually identify fatty liver in the hundreds of thousands of people who've had low-dose non-contrast CT scans. There are literally over 100,000 images. And it is pretty fast to calculate liver fat manually, but it's still a drag. So we're trying to get an algorithm to do it. And goes in and finds the liver. And the algorithm does about as well as you do if you do it manually. Jim had a hand in helping us out with this part of the project. And the paired samplings have pretty good agreement. So we think we are on our way toward being able to identify fat in a brand new group of people. So those of you who take care of people with fat, beware, because hopefully we'll be finding lots more referrals for our NASH study. And I just wanted to comment that, you know, imaging ultimately may be competitive with biomarkers in the serum. Because there really is something to the idea of being able to see what's actually going on. So, wanted to talk a bit about what does SVR do to liver histology among patients with who have cirrhosis prior to treatment. So, let's see. So we have some choices here. We're going to have a show of hands. Okay, so here's the deal. You have people with cirrhosis. You treat them. They have an SVR. You follow them over time. You rebiopsy. When you go back, you start 100% had histologic cirrhosis. When you rebiopsy, how many still have cirrhosis? A show of hands. How many say it regresses in 100%? How about 80%? 60%? Okay, good. 40%? Okay, 20%.
Before you answer, I would point out that we don't actually know yet because the studies aren't long enough to get a final answer.
Not for DAAs, but the best data that we have has a minimum follow-up of 4 years and a median follow-up of 5 years. So, and this really is the best data that we have. And it is from interferon treatment, and my guess is the regression is going to actually be less with DAAs. And the reason I say that is because the population is older. And I strongly suspect that the ability to regress scar decreases with age, but nonetheless, this is what they found. So they did a morphometric study of paired biopsies, 38 patients with biopsy-proven cirrhosis, median 5 years of follow-up, minimum 4 years. Cirrhosis resolved in 60%. Inflammation persisted in 66%. You still had capillarization of the sinusoids, no change in smooth muscle actin. So that's one study, and this slide, which was in part inspired by this very nice summary review that was done by Young Men and Scott. I found all the studies that I could find in the literature that examined this question. This axis tells you the time after SVR, and as Scott correctly opined, regression in 60%. But I want to explain why I think that's very likely to be an artifact and an overestimate. Yes?
Yes. Do you know what's the situation with hepatitis B?
No.
If you have cirrhosis with hepatitis B, you treat it effectively, remove the virus, which is the regression
About
rate?
2/3.
I think much more.
Yeah, at least 2/3, maybe more. The best study was in Lancet from the French group. I forget his name.
Poinard.
No, not Poinard. I'll think of it, but it's at least 2/3, probably closer to 75% over 5 years. From in response to tenofovir.
Just a point about the patients who are treating. Also, don't forget, we're treating much sicker patients nowadays than we were before.
Oh, yeah.
Those were well competent.
Absolutely.
Early childhood.
Of course.
Had good platelet count.
Thank you.
So, and our patients are so much sicker now.
Yes.
A lot of them are just moving to transplant, so you wouldn't even be able to follow it.
Correct.
By the way, the author was Marcin.
I just wanted to say, when we cure these Hep C patients, in the beginning there's a drop in the FibroScan measurement,
Sure.
which is probably related to the
Inflammation. Yes.
And the other thing I've
And
noticed,
congestion.
right? The other thing I've noticed that people who have very low platelet counts, in my experience, the cirrhosis does not, the fibrosis does not regress in these DAA patients.
I think there is much to be said about platelets. I agree. The meaning of that is unclear, but I think it's very interesting to follow up on. Certainly, platelets are a source of multiple growth factors. There are studies where patients with cirrhosis are given, or rats with cirrhosis are given thrombopoietin, and in liver resection models, it seems to enhance liver regeneration. Of course, the liver is the source of thrombopoietin, so if you have a sick liver and it's not making thrombopoietin, you don't have platelets, and platelets are supposed to be providing growth factors, you can see how that could lead to a very problematic situation.
I think the simplest explanation is that I've argued that this is probably the point of no return, is once you have portal hypertension, you have distortion of architecture, you have extinguishing of portal venules, and you have enlargement of the spleen, that's probably a point of no return.
For cirrhosis?
For cirrhosis, yeah. And for the cirrhosis regression after cure.
But the question is why? I agree with you.
Yeah,
why? And I think it could be that liver isn't making platelets because it's got decreased function and poor production of thrombopoietin, and the absence of platelets is contributing to this vicious cycle. So, yes. Now, Jim, you were very good at explaining before. In the absence of a slide that gives the answer, would you like to take a crack at this? I'll help you out. So over here, these are livers of people, and they're getting biopsies.
Okay.
And this red, if you biopsy the red area, that's stage 4. So you can see some people just plain have stage 4. But a lot of people have some stage 4 and some not stage 4. And you've got some people who have no stage 4 anywhere, and you have some that mostly don't have stage 4, but they have a little bit of stage 4. So you're biopsying these people, and you want to enroll people with stage 4 in your study. So this is the line. So you move people into your study group. Now, if you rebiopsied them 1 day later, what would you find? Well, this, you find stage 4. This, there's a good chance you'd find not stage 4. And here, there's an excellent chance you would find not stage 4. You would not find anybody who has gotten more than stage 4, because stage 4 is the highest. So, not by a placebo effect, not by a change in fluctuation of the disease due to natural history, simply due to an artifact of how we select our patients and do our studies, you have a high likelihood that you will detect what you will describe as regression, just as a statistical artifact. Now, Jim, again, how does this apply in the reverse to our studies of NASH?
I think we talked about this previously, where you have sampling error, so we don't really know what the natural history is of NASH in terms of progression of fibrosis and that kind of thing. So I think when you're doing sort of paired biopsy studies, you're not really sure if it's due to just progression or regression. Or
that's too general. I mean more specifically that we have certain bars that we have to clear histologically to enter people into NASH trials. So the reason I say this is the reverse, in the study I just showed, you only could get into the study if your biopsy showed stage 4 cirrhosis. In NASH trials, we've got a lot of people who have very little fibrosis, right? NAFLD. So the majority of the population is kind of there at 0 as far as fibrosis is concerned. There's a little bit with some little fibrosis and then a little more fibrosis. But for our trials, we want to go in and find those people who have enough fibrosis that they meet the entry criteria. So we select those people out of our pool and we enter them in trials. And then unbelievably, we're surprised when we rebiopsy them and find in our placebo group that 20% have regressed. Well, we probably would have found that same regression if we had just rebiopsied many of them the same day. It doesn't all relate to natural variation over time in the disease. It simply has to do with what happens when you go in and you select a subset of patients and you don't put your whole population into the study. So this, in an obscure way, relates to Benno's comment. I really wanted to talk more about platelets, but I ran out of time. So to substitute, I just have this quote from Tom, which is, Tom and I did a study where Tom and Isabel actually went to the OR 20 times when the liver was coming out so they could immediately get the explant and bring it to our lab, where Aaron, who's my graduate student, took out the cells and analyzed them. And Tom came to me in the midst of it and he said, Andrea, when that graft comes out, it's terrible. Like, these livers aren't coming back. And that is our fate, that we are, as Jen says, more and more of our patients are going to be coming in with really advanced liver disease. And our only hope, whether it's through studies of platelets or growth factors or other brilliant investigations and strategies that we can come up with, we're going to have to find out how to promote liver regeneration.
So here's the dilemma. I just spent an hour on the call with a company that has factors that look very promising in promoting regeneration. How do you do that without precipitating or amplifying the risk of cancer? Since many of those factors, you don't have to answer this. Mm-hmm. That's the fundamental dilemma with most of these therapeutics. Unless it's, stem cell based or something based on science we don't understand yet.
I could not agree more. That is why, I know you missed my first opening talk, but this was all about future research areas. And it's very challenging, but it's going to be something that we're going to have to address. And, no time like the present to get to work on it. I described the liver of a patient who's had 30 years of hepatitis C. It's got pre-evil cells in it. And it's also maybe got some good cells. And so the trick is going to be how to call up these non-pre-evil cells and get them to come back. Yes, they're pre-evil. They haven't crossed the line, but they're very tempted.
Okay, so let me put out a thought experiment. I guess we're kind of running out of time. What's really striking to me is that the liver's default is to regress scar and restore architecture. And we see that with Hep B, for sure, Hep C, and maybe NASH and bariatric surgery. So there's this conundrum where highly fibrotic livers can regenerate, and highly regenerative livers don't get fibrosis. So there clearly has to be some signals between those two programs inhibiting one another.
The platelets, yeah.
Do you think it's
I do, yeah.
I think it's more complicated.
Oh, I'm sure it's more complicated, but one of the things, speaking of thought experiments, that has really surprised me as a scientist over many, many years is how often things turn out to be specific. And one of the things I just discovered that a bunch of people working in mice have found is this very strange kind of macrophage that seems very specific for stimulating fibrosis. And in this mouse model, they were able to knock out this type of macrophage. And in lung models of fibrosis, they found it did not have any impact on inflammation. It did not have any impact on the ability to heal from wounding, but it absolutely knocked out fibrosis. So things can, there is a quantum theory to biology as well as to physics, and once we identify some of the players, maybe we can go to town. So, here today, 4 o'clock, please come. We're going to have a great talk from Lauren on functional genomics. Matt Galsky, who has been working with Joe and others on DILI, is going to be talking about checkpoint inhibitors of great interest to everyone. And finally, I want to thank everybody here in the division. It's a great place to work, and special thanks to the people in my lab, Frank and Ahmed and Aaron, Honey, who's been a terrific collaborator, Mark, my research coordinator, and Jim, who actually contributed to many of my recent studies and helping with mentorship of various people, and also a great participant in our discussions today. So thank you.